Dr. Alwalia. So, Dr. Alwalia, please just give us a sense of what is Higher Health, this institution, briefly, before we talk about what it does.
So Higher Health is an initiative of the government of South Africa, which is the Department of Higher Education and Training, all the universities in South Africa, all the TVET colleges. We've got about 26 public universities, and we've got 50 public TVET colleges. About 9 CET colleges, which are community education training colleges. Overall, we've got about 420 campuses. Around 2 million young South Africans every year pass through our system called post-school education and training system. Now, these people are our economy of this country. Right from a plumber, electrician, miner, you sometimes go to Mug and Bean, a waitress who serves you, automobile industry, our fishery industry, our agricultural industry, doctors, scientists, engineers, journalists like yourself. Most of our formal workforce of South Africa comes from post-school education and training. And when I talk about this population, the same population is also a hope of a mother. In an African family, I'm an Indian man, I can tell you from my perspective, every day my mother tells me, now look after your brother's child, pay for your sister's marriage, pay for this. Because we are educated, it's an onus that we earn and we give it. So similarly, the same African child who's going through a post-school education training has to ensure that he becomes the first person in the family, or because of our history, will eventually become the role model where many more South Africans in his brother's child, sister's child, will see him rising because he has a better opportunity to go into a tertiary system and qualify. So when we are putting a lot of investments on financial spheres through NSFAS and many other spheres to make them possible in the tertiary education system so that they can get skills, competencies, and graduateness to go into job sphere, epidemics like HIV, epidemics like gender-based violence, epidemics like mental health, epidemics like TB, epidemics like unplanned pregnancies, they're very high in the youth population. So the same student who comes from a poor background or historically disadvantaged families, even from an advantaged families, the unbound freedom of a university or a college, the same unbound freedom that brings more drugs and alcohol, peer-to-peer, we try to ensure that this young life is holistically passed through, is made sure that we bring a competent graduate out of our system, a system that can take into private sector, a system that can go into government or any job, so that at the end, our economy continues and our work entails. So the Higher Health fights 7 big areas. So HIV, TB, STIs, unplanned pregnancies among youth, gender-based violence, which is predominantly very high and becomes much more higher in institutions of higher learning, challenges of mental health, fighting against issues like drugs and alcohol, our marginalized population, specifically our key population like lesbian, gay, bisexual, transgender, intersexual. One of our studies shows you got 8% of that population in our institutions of higher learning. How do we support them to become graduates? Because they're stigmatized. They can't come out openly. Now, and how do we assist to work the whole population to live together? And of course, also disability, because disability and disabled students are extremely vulnerable to all other epidemics and are also graduates that we want to give back to the economy. So Higher Health that ensures holistic growth of a student to become a graduate and a hope of a family and a hope of.
So basically you're highlighting the fact that they carry the hopes of so many people back home. They have to pay what we normally refer to as black tax. Now, in terms of the programs that you guys have run so far, you've mentioned quite a number of them. How has the uptake been? Before we focus on the COVID-19 one, yeah. How has the uptake been on all the programs that you guys have been running?
So if we have a first curriculum in post-school education system, at 1 o'clock, before 1 o'clock, when you go into a university or TVET college, there's a whole formal education like lectures and classroom activities that are happening. What we developed is something called a second curriculum. A second curriculum on HIV, a second curriculum on mental health, second curriculum on GBV, on TB, on unplanned pregnancies, and all the 7 areas I spoke about. 850,000 young South Africans pass through that second curriculum every year from the post-school education system, getting capacity and skills understanding on issues of GBV, mental health. Nothing better than education as prevention. It is an informal kind of a classroom activity. So all the after 1 o'clock come to us. In TVET colleges, sometimes students have to leave early. So we run the second curriculum parallel to the formal curriculum, but again through classroom in a batch of 50 students. But the aim is, how do we engage young people and capacitate them on all these epidemics, on all these challenges? I think that's our biggest end. So 850,000 South Africans that come through and engage on post-school education second curriculum is a huge highlight for our program. Our second program is risk assessments. Every young person, we would like them to assess their risk themselves, their own risk on GBV, their own risk on mental health. So with the help of WHO, with the help of develop those toolkits that can help in prevention or early detection of our young people towards these epidemics. We also run services. We run wellness days. We used to see you go to a private institution, they always have wellness days every month where people come and check their blood pressures and sugar. Similarly, it happens in our universities and TVETs. But when we thought that these services are only limited by medical aids or for the privilege, which is the academia or the staff, we said we will run a wellness campaign for young students. Every month, 2 to 3 days in a month, with support of vice chancellors and all the principals and campus heads, we find those 3 days during the academic periods every month that we can bring all these services free on the campus just at the doorstep of our young people. From HIV tests to a TB screening, giving contraceptives, blood pressure, cholesterol, you name a thing, to cancer screenings, everything at the doorstep, so that easy accessibility, so that a young child does not need to walk 10 kilometers outside his campus and miss his exams to get an ARV. The aim is, how do we bring this on the campus as far as possible?
Yes. All right. So what is the capacity of Higher Health in terms of ensuring that there's delivery on its mandate, and where do you get the funding?
Various funding. There used to be those days in South Africa, Fundi, we used to have big donors like EU, US government, and many more development partners that used to come. I think 2020, I'm talking about 26 years post-democracy, South Africa has transformed, and I think also we are a upper middle income country. So the donor funding has kind of reduced. My mantra has always been to go with everyone, even if it's little. And I can tell you, two together still becomes 10. And that's what we do. Multiple resources, from philanthropists to government. Very thankful to South African government, who primarily gives us the biggest support. Of course, Global Fund, World Bank, and many more partner countries like United Kingdom and many more. The aim is each of us bring together whatever it is, but build a program that makes it for the next economy to move forward.
Okay. All right. Now, I think that gives a very clear understanding to anybody who's watching about the mandate of Higher Health. Now, before we get to the program that you are going to, share more about, I just want us to talk to some of our guests so that we can come back to you. All right. Siyabonga? Is Siyabonga there?
I think he has to unmute himself.
Yeah.
Yes,
Right.
can you hear me now?
Siyabonga? Yes, we can hear you now. Yeah,
Yes.
welcome to this discussion. I know that we are used to being on the other side, being the one who asks questions to people. But welcome. Siyabonga actually is driving, Voice of Wits, radio. So he is more of a broadcast man within Wits University. And he's got some interesting story to tell relating to COVID-19. Can you briefly tell us, Siyabonga, I know that about a week before the lockdown, you decided that you are going into self-isolation, or self-quarantine because you did not want to be a statistic. Can you just quickly tell us about what you do and what you had to do?
So when the first cases of COVID-19 were reported in South Africa, there was a time where the president addressed the nation, and he says, where he explained to us that we should start practicing social distance and wash our hands regularly, and obviously using sanitizers. And then from there, I knew that as one person who lives with asthma, I'm compromised, so I had to start practicing self-isolation. And then the week after, where he announced that the country is in a state of disaster, where the lockdown was actually initiated. That's where I was already at home at the time, not going out. So basically, what this has done to me is that I'm a person who's responsible, as I said earlier on, to give out information to people across the university community and also the Joburg district as a whole. So this has affected me and also affected the people who rely on us at Voice of Wits FM for information. So COVID-19 has actually affected us when it comes to a person like me not being able to go to the station.
Yes, but the question there is, being a known asthmatic, I'm assuming that you are on some form of maintenance treatment from your treating physician.
Yes. No, I have treatment that I'm taking. I don't have. I used to battle with asthma before, but it's okay now. I'm living with it. It's okay now. But as someone who's immune compromised, I have to make sure that I isolate myself from any possible opportunities that might be there for me to contract the virus.
Yes. And how have things been so far?
Being indoors, yeah, it's different, I must say. It's really different. You starting to do things that you never thought you would do. TV is just not working anymore. It's just TV. It's just like you now. Yeah. It's just something that's there. You don't know what to do with it. But it has taught me a lot of things about obeying the regulations that were given by the government. I think it's important, and as much as this thing will change our lives forever, but it is important for us to stay at home and know that this will be over one day.
Yes. Now, when that first case was announced about a student at medical school at Wits, were you already on self-quarantine, or were you still, doing your work there?
No. When the first case was confirmed at the medical school at Wits, we were still working. I stopped working. I remember the president made an announcement it was a Sunday, and then the following Monday I didn't go to work. I didn't go to work on the following Monday, and then the whole week, the first week I didn't go to work, and then the following Monday, then I went to work. That's where my team and my management told me that, because they know my situation, so they asked me that I should stay at home because I'm compromised.
Okay. No, thank you very much. Let's quickly go to Naledi. Naledi, can you unmute yourself?
Yeah, there you go.
All right. Hi. Welcome back, Naledi. Naledi is a young lady who was in this platform just about 2 weeks ago. She's one of the first people in South Africa to actually go public to say, I was one of the people who got COVID-19, infection, and I have recovered from it. And ever since she shared her story on this platform, we have, have seen that recording, circulating with so many people, impressed by the way she told her story. So anyway, Naledi, can you briefly tell us, about your story?
Hi, Dr. Vindile. Happy to be back on your channel. So for those that don't know my story, on the Sunday, the day that the state of disaster was announced, which was Sunday, the 15th of March, I felt my first symptom. At the time, I was away in the UK, and it kind of posed a serious problem. So obviously going through a series of options, I decided to come home. At the time, I wasn't really sure about whether I had it or not, especially because at that point, there'd been no announcements. And I think it had only been announced as a pandemic on the Thursday, which was the day I arrived. And so it was just this process of kind of trying to figure out how I was going to get home and, taking as many safe precautions as I could. On arrival, I went through quarantine in South Africa, which they stated to check fever. I was asymptomatic, showed no signs of actually having it, so they let me through. But I was just very much convinced that something wasn't right. So got to my doctor. My doctor took all my vitals, checked my saturation, checked my lungs, checked my temperature. I showed no signs again. He thought that he diagnosed me with late onset asthma and prescribed me an asthma pump and anxiety medication. But I insisted that I have the COVID-19 test. And luckily for me, because I had been traveling and I was eligible to test, because at that time, I think they weren't testing anyone that just showed symptoms. You had to kind of have a reason why you thought. So I took the test, and because in the private healthcare system, I think a lot of people have been coming back from traveling and all sorts, so the labs were backlogged. So my results took about 8 days, but in that space of time, I decided personally to self-isolate just because I'd kind of collected some information from friends who were doctors, and they said, if you do think that you're sick, it's best thing that you stay home. And so I was very much convinced that it would be the best decision to self-isolate away from my family in my own room. 8 days later, I got the results, and as I thought, they were positive. But up until that point, really, no one had thought that I really was, because I was so asymptomatic. There was almost no sign of the fact that I was sick, other than the fact that I told people that I couldn't breathe. That was my main symptom, is the fact that I had constricted breathing. So yeah, I forced myself in self-isolation for 3 weeks, even though the recommended time is about 14 days. And now I've been in quarantine I've been at home for over a month now during the lockdown. And I only really came into quarantine and sharing a space with my mother again about last week.
So like you mentioned last time, you said you did not have the tests that cleared you, because of the fact that, they were prioritizing, cases that were being suspected rather than people like you who had been confirmed and had already gone through the 14-day period.
Yeah, no, exactly. So the NICD, along with my doctor. So initially my doctor had said, okay, you've got to come take a second and third test. So in order to test negative, you have to test negative twice consecutively. So that was initially the plan. And then when I called to set up a time to test, my doctor said, right, just because of backlogging initially, which was the big issue as to why I didn't get my results until 8 days later, they're trying to kind of preserve the system. So they want to test new people and new subjects so that they can treat those people versus people that seemingly have overcome it after, the 2-week period. So the NICD has agreed with my doctor, along with the NICD, has suggested that you don't get tested. You just stay in the mandatory 2 weeks of self-isolation. And then after that, you're assumed negative.
Thank you very much for sharing your story, Naledi. And the last person, another guest of ours, is Nebagazi. Nebagazi, can you unmute yourself? Okay, yeah, Nebagazi, can you just quickly tell us your story? Nebagazi is a young lady from the Eastern Cape in a town called Elliotdale. She was the first person in the Eastern Cape to actually be confirmed to have, contracted COVID-19 infection. Nambakazi, welcome to the Dr. Fundi channel.
Thank you very much for having me, Doctor.
Yes, can you briefly, tell us your story? Because after this, we're gonna go back to Dr. Alwalia. Tell us, where you're working, what made you to think that you've got a problem, and all of that.
Okay, thank you for having me. I work for one of the biggest cruises in the whole world, and so this pandemic got us when we're in Italy. Can you hear me?
Yeah, we can hear you very well.
Yes, so it got me when we were in Italy. So we were stuck in Italy because there was a lockdown in Italy, so we had to come back home. So we were booked tickets to come back home. And when we got here, I was okay. I literally had 0 symptoms. So I arrived in East London, I think on the 17th. And when I got to East London, I was traveling with one of my colleagues, and I took a taxi from East London to my hometown, Elletdale, straight to Elletdale. And at the time, because I knew that I was traveling, maybe I got it in the airports or I don't know. But I was very conscious about infecting other people. So I put on my mask in the quantum to Elletdale. And when I got at home, I got at home in the evening around about 7. And one of the doctors who happened to be my friend, he called me and he was like, "Hey, you from Italy? Why don't you go and get tested, because you might infect other people in your family?" And I considered that. So he spoke to one of the doctors in the nearest hospital, which was Madwaleni. And in the morning on the 19th, I went to the hospital to get tested, but I literally had 0 symptoms. I had no flu, I had no cough. So I went there and I was communicating with the doctor in the hospital. And when I got there, I asked them to quarantine me there because at home we're about 10, 11, and I live in the rural areas. So,
What kind of a dwelling do you have at home?
It's rural areas,
Rondavels or
yeah, because we have a house at home, and also there are rondavels. But people visit it in the rurals. People don't care about the quarantine and the staying at home, social distance. They visit each other, So when I got home on the 19th in the evening, I practiced social distancing. And I was like, I'm not going to hug anyone. Yes, I know I'm from Italy, but I'm not going to hug anyone because, you might get this thing. I don't know if I have or I don't have it. So in the morning on the 20th, I went to the hospital and I got tested, and I asked them to quarantine me there because we are like many at home. I cannot quarantine at home. I have a son, I have nieces, nephews who are like 10, And yeah, on day 5, results came back. Oh, there was already speculation on Facebook that there is a lady in Madaleni who tested positive. By that time, my results were not yet back. And people were talking, some other people were creating groups, planning to kill me because they were like, it's better that there's one person who dies than all of us, because she came back to kill us all. She was bought. I don't know by who, but to bring the virus in the rurals. So, that thing got to me when I was on social media, on Facebook, to be specific. I was like, oh, wow, people are thinking all those kind of things. People need to be educated about the virus because they're so misinformed, So on day 5, my results got back on day 5 in the morning, and I tested positive. And anxiety, fear started to kick in, because I was like, oh, wow. I didn't think I would test positive because I literally had no results. And where I was working, the doctors were like, okay, if your temperature is 36 or less than 38, you are normal. Don't be afraid. You won't have this thing. And my temperature was fine. All the time, my temperature was fine. Even when I tested positive, my temperature was fine. So I started to educate myself about the virus, and I read an article and I found out that the virus is actually afraid of heat. And I was hitting myself, exercising each and every day, drinking hot water, drinking vitamins, making videos, just to let other people know that there is still hope. And on day 11, I retested again, which came back on day 14 negative. And I went home.
So I understand that there was a bit of stigma when you went back home.
Yes.
There's a lot of stigma and discrimination that you experienced. We're going to go back to Doc now. Yeah.
Yes,
yeah.
There was a lot.
Yes, you can continue.
There was a lot of stigma. People were calling my family Corona family, and people were threatening. I received a call, I think on day 9 in the hospital, I received a call from Anonymous saying that they will come in the hospital and kill me because I came back with this virus to kill everybody in Elliotdale, So there was a lot of stigma and things were said. Even the nurses were afraid of me. Nobody came to check up on me, in the hospital. Like everyday routine, people coming check up on me. No, everybody was afraid. There was a lot of stigma, even in the nurses, even in the hospital, there was a lot of stigma.
Thank you very much for sharing your story. It's very enlightening because it's important. I mean, some of the people that, Doc, you are looking to provide your solutions to are actually people who are in the rural areas. So her story, I think, will resonate with a lot of people who are in those underprivileged areas. So Doc, let's come back to you now. And can you just tell us then, all right, you've been running all these programs, and obviously now there is the COVID-19 pandemic, which adds to the plate that was already full. You have been looking at how the pandemic is going and how it's maturing within the South African context. What happened then? Clearly there is something that you guys had to do. Can you just take us through then?
No, I absolutely agree with you, Fundi. This COVID-19 was not anticipated by any of us, not only in South Africa, but globally. A very new virus, a virus that we do not know much about. All we are relying is new global data that's coming in. There's no treatment for this virus. There's no cure, there's no vaccine, very similar to HIV in practical reality. So I think what we've learned from HIV as a virus alone, what we've learned is we had a tool called prevention. And I think we went full blown as a country trying to do what we knew best was prevention in order to fight HIV. And I think as Higher Health and any other organization to call on what the president has called for a solidarity plan, our work should be is what we know best, capitalize on what we know best, build on it, and fight this virus called COVID-19. It's a virus at the end of the day. What we know about this virus, how it spreads. We have now known where on the surfaces it stays, what can kill the virus, like cleaning hands, using detergents, properly sanitizing ourselves. So we know, if we don't know everything about this virus, data is now coming to show us what we know about, a little about this virus. So what do? We fight this virus through prevention. Now, the first thing that prevention comes into my mind is education, and nothing better than education as prevention.
Yes.
The other thing we did very well in HIV through prevention was not only education, but we did was testing program. Probably South Africa's biggest testing program when it comes to HIV prevention. And now, I think we are now going to scale this up towards testing, because testing is also prevention. More we we will test people, more people will know their status, more we can do contact tracing, more we can request people to be isolated, more we can quarantine people, and more we will allow this virus not to spread more. So I think that's where the entire system of post-school education or higher education or school education should be built on what we know best, use prevention as a methodology. We're going to start now running through social media campaign in trying to educate what is something called authentic information. The first step was to partner NICD and Department of Health, get the correct information from WHO into the reality. I think what's going to kill this virus and us practically will be is fake information, myths, and that will create stigma. And I think as much as social media is an absolute necessity for us to educate and transfer good information, social media can also become our enemy by making people transfer or follow wrong information. And there's a lot of wrong information traveling around. And I think what my first request will be is, as Higher Health in any organization, is to ensure authentic information goes out to people.
Yes.
We have an army of about 5,000 peer educators, our student volunteers. Through you and through many media channels, we need to reach out to our student community and galvanize them. And that's what we're doing. We're partnering with a network provider like Vodacom and many others, in telecom especially, where we are trying to say, can we do a zero-rated webinar where we will pay back them, service provider, but our students can join in, specifically our foot soldiers. These foot soldiers are in rural areas. Exactly your point. They are in communities, they are informal settlements. TVET colleges are primarily in our rural areas. We have campuses in Alexandra, 7 campuses in Soweto, in Kailicha, in deep down in Bizana, in Mandeni, in exactly everywhere our communities are. If we build educated South Africans to understand from post-school education, we've got 2 million of them, through our 5,000 foot soldiers, educate them on COVID-19, they can fight a lot of stigma by educating their own families, their own community, their own family members. You can see a ripple effect from 2 million educated South Africans by passing on educated information on COVID-19. And education will be key at this moment. Asking them to, if they have symptoms, to test. The Department of Health has now put, and we are putting as Higher Health, new nursing staff, adding on to our existing staff and putting community healthcare workers to do testing on campuses. Yes. At least screening them and putting them to linkage to care immediately so that we can get results quickly. And then if they are positive, we do contact tracing and start isolating people more quickly than it would be, because this virus can still be transmitted even if you don't show symptoms. So we need to contact trace very quickly and put people on isolation or self-isolation or quarantine if they can't self-isolate, so that we can stop the spread of the virus. And that can come only if education comes first, capacity building comes second, communication to each and everybody in the community comes with authentic information, and then our teams start doing contact tracing and preventing the spread of the virus. And that's break the backbone of the virus from the middle. And I think that's exactly what Higher Health is going to do. From communication, from social media to authentic information, and building an army around the communities.
Now, if we, think back during the height of the HIV and AIDS pandemic, there was a time where stigma was very high, discrimination was very high, and it took people who were living with the illness or prominent South Africans to actually, come out. People like, our former president, Nelson Mandela, who stood out and said, my son has passed on as a result of an AIDS-related illness. People like, Nkosima Ngosuthu Buthelezi, who also said, my child passed on because of this. So I think, having people like Naledi and Nebagazi saying, I have contracted the illness, I've gone through the illness, the symptoms were atypical, were not the usual symptoms that everybody is talking about, but I tested positive. However, I have now recovered from the illness. How important is that kind of message?
to defeat any virus or any disease which has a stigma related to it, nothing better than a peer to a peer. Naledi is the correct peer. Willie is the correct peer. Miss Willie is the correct peer. Sia is the correct peer because they have gone through self-isolation. They have experienced what it is to live with the virus when they became positive. What it meant to be overseas, come back to South Africa, carry a virus, and be in the community when the community found out that they had the virus. And how they went through. They have gone through a very horrific kind of a journey, and they have now recovered and they come out and they're speaking about it. And we need to build soldiers of that kind. And that's the real peer I'm talking about. As much as we'll have educated South Africans or higher education community or peer-to-peer education, but the real peer is the one who was positive and the one who can relate the story. So I'm very proud of you, Fundi, of the step you have. It's an early infections. They're early stages. We only have about 2,700 people who are positive, and most of them are still recovering, and very few have recovered. Yes, young people recover faster than the elderly or the people with comorbid conditions. So whatever people who are recovering should become the change agents, should become our force to go out and speak about it. Educate communities, because stigma happens from uneducation or people who are not getting the right information and not understanding what this virus is. And trying to explain communities how to live with this virus, because the practical reality where I sit is South Africa needs to prepare to live, to survive with this virus for a bit of a long time. Then it is anticipated, was anticipated. And if we are aware that we have to live with this virus, and we have to survive with this virus, our economy cannot be put on a lockdown forever. And this virus stays with us. We know its prevention is there. How do we build our communities to say, well, we got a challenge. Globally, it is a challenge, and how we can do it. And I think these peers will help us, Fundi, to win this.
Yes. Now, yes, another issue, Doc, that I want us to just quickly touch on. I'm very happy that you guys are adopting the prevention approach, which is health promotion, information dissemination, whilst we are also looking at early detection and encouraging things like flu vaccination and stuff, so that people don't have COVID and flu. Now, my issue, I just wanted to, we sometimes see that it's not always that when somebody has got information, it translates to change in attitudes and change in behavior. As we have seen, I hope I won't attract a lot of negativity from my colleagues, but some of the worst alcoholics, are actually medical people. Some of the chain smokers are medical people. They know exactly what alcohol and smoking does. You see, so the information they have, but the behavioral change, the attitude and behavioral change is there. So, and they always say, information, you have to keep on. So are you guys looking at ongoing information dissemination and making use of change agents on the ground?
I think we need to use every tool we have. I think as you rightly started with HIV, you've touched my own community, which is medical doctors and information that sometimes doesn't relate to people and health promotion, sometimes do not work in the way we have always approached to. So what do we do in such situations is, the peer-to-peer education, we know it's effective, it's worked in the past. We've seen it working for other viruses and other epidemics that South Africa has encountered, whole global data has seen. So we have to utilize that, because education is power and prevention is education, there's no doubt. And in a way, in authentic, good information is critical. But one thing we need not forget is the biomedical approach. And the biomedical approach is scaling up testing, scaling up isolation, scaling up quarantine centers. People who cannot self-isolate, we have to put them into quarantine ourselves. We have to put what we call it, involuntarily self-isolation or involuntary isolation. If an institution of higher learning finds out that I am positive, or I was in contact with somebody in my family who was positive, they must tell me that I must go and isolate, or they must force me to isolate because I am a threat to many more, because I can spread the virus. And I think involuntary isolation, quarantine and isolation, the words that we have been listening for last 4 months, have a very important reason in prevention. These are both social, behavioral, and biomedical interventions that we talk about. And all of them have a role together. So social scientists, biomedical scientists, behavioral scientists, we all need to work together if we have to defeat any disease or an epidemic. It's not just the Department of Health or health can ever fight it. So what I'm trying to say, Fundi, is education is a tool, testing is a very big tool, screening people is very important tool, contact tracing is very important. And I think when I spoke about foot soldiers, I spoke about foot soldiers to be galvanized or trained in all the parameters. Education, helping in contact tracing, bringing it to testing program, and informing, ensuring that we have isolation and quarantine. And that's why we've just developed our PSET guidelines, which are post-school education and training guidelines, that goes in detail for our accommodation program, waste management, refusal disposal, environmental cleaning, cleaning of classrooms, how much should be code of conduct for students between social distancing, even in a classroom, should we have to go on to contact classrooms. So the point of departure is that we need to look at everything holistically and scientifically and prove it what is correct, educate our communities in the most simplest possible way and fight this epidemic.
Now, Doc, you obviously working with so many institutions, like you mentioned at the beginning. How are you going to ensure that they implement the guidelines that you guys have developed? Because we don't know when the lectures will resume, but when those lectures resume, there will be cases that will come out within those institutions, and those people will need to be isolated whilst the studies continue with the other students. So is there a way, or is there a way of ensuring that there is implementation by all the institutions? Can you just talk about that?
I'm a member of the ministerial task team, and I'm grateful to the Ministry of Higher Education, the whole department, every vice chancellor we've spoken to, and every TVET rector we've spoken to. What we are planning is not just the dissemination of a guideline. Yes, guideline is a toolkit, it's a whole document that every management or community needs to understand what to do in order to engage an epidemic that's right at the corner of our institutions. But what we need now is to start developing capacity building. So we take these guidelines and we cut into pieces. So from next week, we are doing live webinars with senior management, with student affairs, because student affairs will be directly in touch with the institution residences, with the student community, building our campus clinics, our nurses in the clinics, our community healthcare workers, a specific webinar only for our pure educators that I spoke about, data-free webinar, that we want to, so that each guideline needs to be broken into slices, develop protocols, develop algorithms, and capacitate each. What strength I have is, at this moment, is buy-in. Buy-in from all 76 institutions of higher learning in South Africa, and their 420 campuses, who are hungry to be educated and hungry to put these systems together. And it's not going to be alone them. It's going to be them with us, Department of Health, and our community systems together, which holistically puts the infrastructure together and monitors it. So I think it's going to be a difficult fight. It's not easy, but I think with the buy-in and what we have with together, I can't say we'll win it, but we'll move strides into it. Because this is a new virus, and I think any predictability at this stage is very tough for any one of us.
Now, as the person who is driving this program that's about to be rolled out, what measures are you going to be looking at to see if you guys are making the difference, in terms of your strategic objectives?
I think what we're trying to build up is a dashboard, an immediate monitoring and evaluation dashboard. Any person who becomes positive in any campus, we can start seeing the positivity rates of the COVID-19. And from that positivity, we just start running around with the contact tracing. And I think if that M&E data system can become stronger centrally to coordinate 422 sites across South Africa and start putting, and we can start seeing where the dip is happening. We can talk to the management, we can talk to the local authorities and say, what's happening? Why are we seeing a trend of increase suddenly in one of those campuses there? And immediately putting infrastructure to that quickly. I think the quick decisions, quick interventions, early control of an epidemic by seeing a trend that's getting into high risk into a particular area will make a lot of difference in such a virus cases. So surveillance through dashboards is a very important tool that we need to deploy, and not for just the main campuses, but satellite campuses right in rural areas that we can pick up the trends quickly and the data starts coming in.
Thank you very much. Let me go back to Siyabonga. Siyabonga, can you unmute yourself?
Yes. Can you hear me?
Right. Now, Siyabonga, you've got only 2 minutes. I want to hear from you. You are in a strategic position of being part of a radio station within a big campus, of Wits University. How are you going to ensure that what you do is aligned with what Dr. Aluwalia has just, communicated?
The first thing that I can say is that with most people especially young people, the biggest challenge that we have is the language most of the time when it comes to understanding what the government is saying and also what Dr. Aluwalia has said. I think if the government and other media houses were to try to convey the message in all different languages that we have in South Africa, including French and Portuguese, it would be easy for everyone to understand, because I think we miss certain things because of the language and how the message is communicated. So I would actually challenge, or actually ask the government rather, to make sure that all 11 official languages are used to convey this message, and also media houses, because we have different radio stations and TV channels that broadcast in different languages, to spread the message across the country. But as a station, we are, as soon as we have a format on how we're going to work under this condition, we will definitely make sure that we convey the message that Higher Health is trying to push out, and also their work also heard across the country. But I'm very specific on the language. I think the language issue has caused us a lot of issues, especially coming back from the HIV epidemic that we had years ago. The language was the problem that also caused stigmatization, and also the lack of education amongst young people at the time. So language is very crucial on my side.
Okay, so you are actually, promising Dr. Aluwalia that from your sphere of influence, you will definitely, help them achieve their objectives. Definitely,
that's our duty. Our duty is to educate, entertain, and also inform people. So it's very important for us to promote what Higher Health is doing.
Thank you very much. Naledi, I know you can unmute yourself, yeah? Naledi? All right.
Unmute now. Can you hear me?
All right. Yes. Now, yes, you are working now, but you were a student not long ago. You graduated from UCT. So I'm sure you're still very fresh in your mind in terms of the whole, campus feel and how things happen there. Just before the lockdown, we were seeing videos of young people partying, corona, and they really were not bothered by the corona. So what message do you have for, people of your age who are still at tertiary in terms of, caring for themselves and making sure that they help to flatten the curve?
Yes, that was probably one of the biggest things. Is I think I also at some point didn't take it seriously because I was seeing, Corona dances and all the information seemed to lead to this thing not being a Black issue, not being a young issue, not being an African issue. And I think I really had to kind of learn the hardest lesson in that I'm young, I'm Black, and I'm African, and I did manage to contract Corona and COVID-19, and even worse, I contracted it here in South Africa. So I think it's really important to recognize that, looking at myself, I've managed to recover. My immune system is quite strong, and I've, been fairly asymptomatic up until now. But there are going to be people around me who aren't that way, who have weaker immune systems, who are high risk or have pre-existing conditions that will affect them. And I think that's the most important angle to come from, is don't necessarily do it for yourself. You do it to protect those around you. And if you have to relate it in some kind of way, then think about your grandmother or think about your uncle who is diabetic. If that helps you scale just how important it is to take care of yourself personally. But yeah, I think that's the most important point, is take care of yourself. And that is literally your civic duty in taking care of others around you.
Thank you very much, Naledi. Ncebakazi, you've got 2 minutes. I've got 5 minutes that I have to give to the doc to close. So, Ncebakazi, what are your parting shots to abantu emakhaya? The people back home. How do you ensure that you use your experience to actually change the mindset, not only of the people at Xhosa in Elodale, but also generally the people in the Eastern Cape. Eastern Cape is now number 4 in terms of cases in South Africa. And the numbers are shooting up very, very quickly. And they seem to be linked to things like funerals. People don't want to keep their funerals to be, max 50 people. And so we are seeing that problem, especially around Port Elizabeth, especially now around East London, with the prison there, and also in Transkei. So what role are you going to be playing to make sure that the people of the Eastern Cape take this pandemic seriously?
Thank you, Doctor. I've been educating people. I live in the rurals, right? So I've been educating people on social media, and I've been sharing on groups, and I've been encouraging people to stay at home and stay active and stay safe. It's when they say stay at home, it's like they're doing it for our own good. The government is doing it for our own good. It's for a good cause. So people should stay at home and stay healthy and safe,
And wash those hands.
And wash hands regularly. It doesn't matter with soap or what. You can wash your hands with sunlight if you have sunlight, just with soap, Yeah.
Thank you very much, Kesiswamne. Doc, let's get back to you. You're going to wrap up this discussion, but there's something that Siyabonga mentioned, which was around use of local languages. It's an area that I also have been a bit, concerned about, because whilst people know English, but sometimes to actually decode the information in a way that they understand, it's sometimes better to do it in Vernac. To that extent, I'm in the process of recording. I've already recorded Xhosa, Q&A in Xhosa, Q&A in South Sotho, Q&A in Sepedi, which is North Sotho. I'll be doing Venda and Tsonga next week. And I'll make those available to whoever that wants, so that, because it's explained in that language, and there's hardly any English in it. So I think that's one thing. I can also make that available to Higher Health as well. Now, Doc, I want you to, just before you close, there is an issue that we did not touch on very well. The perception by youth that they are somehow, not at risk of this, in spite of having the 2, young people, 3 young people in front of us. Can you just touch on that and then you wrap up? We have got just about 3 minutes.
young people, and it's a total myth, every one of us, myself, yourself, Dr. Fundi, Naledi, everyone, Sia, and Miss Willie, every one of us are equally susceptible to get coronavirus. Because that is why it's called novel, because none of us, any human, doesn't have any immunity to such a virus. What does that mean? Is if you do not have an immunity, which means you are equally susceptible to the virus. Now, what young people are equally susceptible to this virus, but they might not be having a severe infection or say infection severity kind of an infection, which the elderly or people who are immunocompromised or people who are living with comorbid conditions will experience. Now, in such a situation, in a country like Africa, in a continent like Africa, where our youth is predominantly the majority population, they are fragile, they like to go out, it's very difficult to keep them in a lockdown. And that's youth, youth means to mobile. They will be the carrier of this virus. And that's a fear, and they're not responsible because they'll carry the virus, they are equally susceptible to the infection, but they will then transmit to the elderly or to the immunocompromised. And Africa is an immunocompromised continent with lots of people who are suffering from comorbid conditions. And that can be fatal. So I really humbly plea to everyone that young people must never ever imagine that they're not susceptible to this infection. They are equally, in fact, more because of their mobile nature to this infection. Their number of cases are more higher at times than even elderly in getting the infection. Yes, the fatality rates will be higher in elderly or people with comorbid, and they can be the carrier or a cause for that. So responsible youth is the biggest message, Dr. Fundi. We need to reinstate or re-emphasize, because I do think in a continent like ours, a youth will play a very significant role on how we tackle the COVID-19 and prevention specifically, because they can transmit this quite quickly. Answering Sia's question, just to wrap up, Dr. Fundi, and utilizing this time, not only WOW FM, which is a brilliant radio channel for our WITS University, like them, we've got another 20 of them. Higher Health, for what we learned from HIV, gender-based violence and mental health, have been working with about 21 radio stations across our country, which are campus and community radio stations. Right down in Unitra FM, which is down in Transkei, has a 600,000 or 400,000 listenership of young people. As you and I are speaking today, they might be telecasting this. And they will engage it in Xhosa, in the language in Transkei, or in Eastern Cape, where people will be able to communicate. So our aim will be to capacitate over 220 radio journalists or many more SIAs in our organization that we have, so that they can then take the education and transform it into simple. We've got 11 languages and communicate. Nothing better than a peer communicating to another peer. When we capacitate 5,000 foot soldiers, most of these people are in rural areas and they speak the language. Even Zulu changes in Ladysmith to what is spoken in Durban. And I think we need Ladysmith. We need young people in Ladysmith who can communicate further in the same language that their peers understand, and the same kind of a slang that they use, so that it's more effective and efficient. So I can't agree more than Sia that a language can play a very massive role. And in a country as diverse like ours, and diversity is our success. So we need to pick up these 11 together and build it together. So Dr. Fundi, I need your videos, and I think we need to all work together. Prevention is what we have. And I think all I can reinstate is prevention, testing, isolation, contact tracing. I think if we do it properly, we can win anything. And I think we've shown it in the past. In fact, South Africa should show to the world what prevention is, because we've run the world's biggest prevention program for diseases that was unique to us.
No, I want to thank you, Doc, for talking about the program that you're about to embark on, making all those young people aware that there is caring, from your level and in all the institutions but also, engaging people like Naledi, Siyabonga, and Nebagazi, so that they can play a role. Somebody like Naledi, is a professional. She even creates content herself, so she could be somebody that could be useful to work with you. So I want to thank everyone who was watching this transmission. My understanding is that was also carried through SABC Digital as well, as a way of ensuring that as many people as possible have access to this. The video will be available on www.fundilenyati.com. Within the next 5 minutes, then people can download it from live broadcast and share it widely. And we'll also make the actual file available to Higher Health so that you can cut it in whatever way that you want to cut it. So I want to thank you and also thank all our viewers and say we hope to have another discussion like this in the near future. Thank you, everyone.
Thank you, Dr. Fundi. Thank you very much.
Thank you.
Very, very thought-provoking discussion there amongst the panelists, Dr. Ramalik Aluwalia, who is from a department called Higher Health within the Department of Higher Education, and as well as some of those young people who've been infected or affected by COVID-19. Among them, Ngabagazi Willie, who is the first case of COVID-19 in the Eastern Cape. Remember that she was a subject of nasty rumors going around the province, saying that she was paid to spread the COVID-19 pandemic. And this discussion was hosted, as we've just seen now, by Dr. Fundi Lenyati, who is a medical expert. Thank you so much for tuning in. And this is the agenda on SABC News. I'm Simpio Ngona. Thank you so much for joining us. Let's take a quick break. We'll be right back.